Welcome back and a warm welcome to anyone who's just joined us for the afternoon session. I'm Associate Professor Gillian Broadbear. I'm the Head of Research at Spectrum, and you are currently tuned into our Spectrum Research Forum, our very first. Now, we'll begin the afternoon with a rapid fire session, and for people who may be unfamiliar with that setup, it's people coming in and giving a presentation in an abbreviated form. So we have about 10 of these, and because of the speed with which you'd have to transition between people slide sharing and zipping around to different people in different locations, we have pre-recorded these. Now, although there won't be a live Q&A at the end of each presentation, each speaker will be online and available to respond to your questions via the Q&A. So please don't just think it's all pre-recorded and they're not there. They will be present and they will be monitoring the Q&A. So you are most welcome to post your questions and comments during their talk, and each of the speakers will be able to reply to you during that time. So please continue to type your questions and comments and enjoy the rapid fire session. So our first rapid fire presenter is Dr. Helen Mildred. Helen is a good friend and senior lecturer in postgraduate psychology at Deakin University. She's also a senior clinical psychologist at Eastern Health Child and Youth Mental Health Service. The title of Helen's presentation is Methodologies, Mentoring and Manuscripts, a research partnership between Spectrum and Deakin University School of Psychology.
Hi there, my name's Helen Mildred, and I am a senior lecturer at the Deakin University School of Psychology. And I'm going to be talking to you today about methodologies, mentoring and manuscripts, which is the banner headline, if you like, for a research partnership that's developed between the School of Psychology and Spectrum over the last 7 years. I just wanted to acknowledge all the people on the front slide there who've worked hard to be part of this collaboration and really added to its growth and strength. There's a lot of history around in terms of the collaboration between Eastern Health and Deakin University Psychology, and I'm not going to go into it in great length, other than say it's been in place for about 23 years. And it was originally set up with looking at trying to support training and workforce development and also research. I think it's fair to say at the end of the 90s, universities were starting to realise they needed to do much more applied and relevant research that was going to be more able to have an impact on the general population. And so partnerships were starting to be thought about. Today, I'm going to be speaking about 4 different projects that were actual theses, doctoral and master's theses that were undertaken through Deakin Uni, but in collaboration with Spectrum. And between the 4 theses, I think about 10 different studies came out of them. And so I'm going to do a kind of whistle-stop tour over these and talk a little bit about how the partnership has grown. So Jen is the first person that I'd like to acknowledge, and she did a study looking at some of the risk factors, particularly in relation to who is most at risk of dying from suicide or accidental harm with personality disorder. And she did a couple of things, and one of the things was that she looked at evaluating the risk assessment protocols from area mental health services in Victoria, as well as doing a file audit to compare people who have died with BPD to those who have died from major depression, and looking at whether there are similarities or differences, particularly unique differences that may assist in the future risk assessment with people with a personality disorder, particularly borderline. Okay, so the findings were that 9 of the 13 area mental health services risk assessments were reviewed, were returned to us and reviewed, but only 1 actually aligned with the BPD specific risk assessment principles that were developed through the National Health and Medical Research Council's guidelines. And when Jen did the file audit and compared those who had died of with BPD compared with those who had died with depression, She found that there may be a key sort of hierarchy of risk factors that that cluster for people with BPD, and some having more kind of weighting than others, and that a combination of these key risks, spearheaded by a recent relationship breakdown, would often present a really high risk of death by suicide or accident in people with that diagnosis. Julian Nolan did an MPsych, a master's program, looking at the relationship with BPD and sexual diversity. He was looking at the statement that people with BPD have been shown to be more likely to identify or be identified as sexually diverse. He wanted to know why this was so and what are the lived experiences of people living with BPD who are also sexually diverse. He looked at an online survey of 162 people with BPD, 58% of them identifying as sexually diverse. And he also did 4 really in-depth interviews, qualitative studies with people with BPD who identified as being sexually diverse. And his findings were that there were no differences between the 2 groups, if you like, sexually and non-sexually diverse, i.e. heterosexual people with BPD, on their levels of BPD symptomatology, their sense of identity, or their impulsivity, which is contrary to previous findings in the research. With the interview participants, he found that the key findings from them were that sexual diversity should not actually be seen as a symptom of BPD through the lens of identity disturbance. Where appropriate, of course, clinicians should non-judgmentally explore a person's experience of their sexuality if it's relevant to their presentation. And he also found that his findings did not support the idea that there's a higher incidence of sexual diversity and that it's related to these challenges of sense of self or identity. So that's quite interesting study that found those things. Dylan was a master's student also who looked at chronic pain and BPD and examined the incidence of it in people attending the Spectrum Assessment Clinic, and also to gain an understanding, once again, of lived experience of chronic pain for those with BPD. He did an audit of 145 consecutive assessments at the clinic and in-depth interviews with 4 people living with chronic pain and BPD. What were his findings? Well, he saw that 38% had in their file recorded chronic health complaint, even though it wasn't a specific question on the assessment protocol. So it came up in 38% of situations. So it's pretty high, with 20% in the general population. Interview participants of 4 in-depth interviews were found that the chronic pain, the BPD tended to precede the chronic pain. The chronic pain tended to come after the diagnosis of BPD. And they found that a thing that helped them was connectedness to a supportive person. Things that people reported made the chronic pain worse were the grief and change of identity that chronic pain brings, the limiting that it can involve of people's functioning and ability to do stuff. And the way in which the chronic pain made the BPD worse was to add a real sensitivity and intensity to their experience of emotions. They would feel more angry and more distressed than when they had the BPD alone. The final study I wanted to mention was that of Emily, who looked at romantic relationships and attachment in people with BPD. And she wanted to look at the romantic relationships of people with BPD and understand their lived experience of those relationships. She did a couple of studies. One was an online survey, which was completed by 205 people, 134 identified as having BPD, and that she was exploring attachment, caregiving, and conflict styles in those people. And the second was looking at in-depth interviews, once again, with 12 people in 6 couples where one person had BPD, and there were 6 heterosexual couples who had rated their relationship as being at least moderately satisfying. And what did she find? Well, it's very hard to sort of cram these things into a few lines, 3 or 4 years work, but people with BPD were in general found to be less trusting of and satisfied with their partners, and they were often less active in conflicts than their partners, and also reported at times they found it harder to offer comfort to their partner if their partner was distressed. The interview participants said that when we were interviewing the couples, they said that they both would report, because they were interviewed separately, they reported that they were similar to their partner in terms of their commitment, mutual interests, and both trying to do their best in terms of communicating, trying to understand each other. Both people in the couple spoke of using DBT skills to communicate, soothe, and take space to calm down and come back together to apply solutions. And people with BPD were described their partners as being a safe haven, often having the skills to help them calm down. So look, the final slide really just brings it together. There's been a very successful collaboration, and fortunately these days time and resources are actually put into these things, because health services often don't have the time or the resources to do it, but more and more health services are putting aside those times and resources for people to be funded to actually undertake research as part of their role. There's been lots of creativity and flexibility in the program, and bringing lots of different research skills within the team, and the value and endorsement from the hierarchies of each partner, from Deakin, but also from Sathya and Gillian at the helm of the research program at Spectrum. And I thank you for your time.
And we thank you, Helen, very warmly for really working closely with us and promoting the relationship that we have with Deakin University and bringing HDR students through our program. Helen and I are advertising at least one project at the moment, so we really appreciate her and her great mentorship to research students. Our next rapid fire speaker is Dr. Fiona Donald. Fiona is a colleague and clinical psychologist who works in the acceptance and commitment therapy and mentalised-based treatment teams. Fiona has a particular interest in the lived experience of BPD treatment. Her presentation is called Ultra Brief, Acceptance and Commitment Therapy Treatment for BPD. Can it work?
Good morning, my name is Fiona Donald, and I'd like to share with you a brief intervention for BPD, an ACT intervention based on the observer self in particular. I'd like to acknowledge the research team, which is myself, Agreed Al-Khwazab, Gillian Broadbeer, and also in particular the Wise Moments clinicians, Clark Collins, Lorraine Sinclair, and Tanya Whittleton. So what is Wise Moments? Wise Moments was a 4-session intervention for BPD with a focus on the the observer self, as I've just suggested. The observer self was seen as the key catalyst for change. I'll come back to more about the observer self in a minute, but very briefly, the concept of the observer self refers to the ability to respond to thoughts and feelings as thoughts or feelings, rather than in ACT terms getting hooked into the content of those thoughts or feelings. So Wise Moments was also a clinician-developed intervention. The intervention was designed by Spectrum clinicians Clark Collins with Tanya Whittleton. And I think that's particularly important for this intervention. I'll share with you some of the results later on. But I think I guess the experience and the intellectual property that the clinicians brought to this project was very, very important. I think it's also important to mention that Wise Moments is part of a suite of interventions. So it is, in a sense, part of a stepped care model. Wise Moments, as I've mentioned, is a 4-session individual intervention. Wise Choices is a 20-session individual intervention over about 6 months. And Wise Experiences is a 10-session group intervention. So what the Wise Moments intervention really consisted of was based in the idea of suffering as it's conceived of within an ACT framework. An ACT conceptualisation of suffering tends to suggest that people naturally focus on the content of thoughts or feelings. So they get, in ACT terms, hooked into the content of a feeling or a thought, rather than kind of stepping back and just seeing that as a feeling that will pass or a thought that is a thought, not a fact. So as an example, ACT would encourage somebody who's having the thought, I'm a fool, not to get absorbed in the elaborating how they're foolish or what that means to be foolish or a fool, but rather to sort of step back and say, well, that's a thought I'm having. It is just a thought, it's not necessarily a fact. And that could apply to all sorts of other thoughts or feelings that we have. The observer self is, as I've kind of suggested already, that ability to step back and see a thought or feeling. And I think the importance of that ability to step back really rests in the fact that if you can step back from a thought or feeling, it tends to take some of the emotional power out of that. And I think limits the ability for suffering in terms of how you interact with your emotions or your thoughts. Cultivating the observer self was at the heart of the Wise Moments intervention. I think also very importantly within a contemporary conceptualisation of ACT, it was about participants in the program really experiencing the observer self for themselves rather than being told what it was. So clinicians were very, very aware of the need to guide the client through the experience of stepping back from thoughts or emotions, rather than clinicians didactically explaining the concept of the observer self. I think from my experience, and I think other clinicians might also have observed this, it's when somebody actually has that experience going, okay, I'm having a thought, rather than being told about what the observer self is all about. That's when the therapeutic gains are made, I think. So why a ACT brief intervention? As I think many people know, ACT stands for Acceptance and Commitment Therapy and is a third wave cognitive behavioural therapy. But we felt that there were key characteristics of ACT that make it particularly amenable to brief intervention formats. Notably, ACT is a transdiagnostic modality. So the goal of ACT treatment is not, for instance, to reduce anxiety in the context of an anxiety disorder or to address specific symptoms of the condition. That might happen as a consequence of the intervention. The intervention aims at increasing psychological flexibility and is accordingly a transdiagnostic treatment. The form of a particular behaviour such as depressed mood, excessive anxiety, non-suicidal self-harm or substance use is not considered to be of great importance. It's the function of the behaviour that's the focus within ACT. So we felt that these characteristics of ACT as a modality made it a promising basis for a brief intervention, which is why we focused on ACT as the basis of a 4-session very brief intervention. Why ACT for BPD? There are, of course, a number of longer duration interventions in the Australian context, particularly dialectical behavioural therapy, DBT, and MBT, mentalisation-based treatment. These treatments usually are offered for 12 to 18 months or even 2 years at times. And they were never really conceived when they were designed to be brief interventions. And it might actually be that it's fairly cumbersome to redesign the specialist therapies to briefer treatment durations. In contrast, ACT was developed as a transdiagnostic intervention and may be more readily offered as a brief intervention, and has in fact been offered in different contexts as a brief intervention. We also considered the consumer preferences. Commitment to a 12-month or 2-year therapeutic program is not necessarily desirable for all consumers. Further, it may be important that treatment engagement and retention, that people diagnosed with BPD find a different way of relating to painful emotion early in treatment, so that some of that suffering that's very much part of the clinical picture of BPD, I think, is addressed very, very early in treatment. So just to summarise, the rationale for Wise Moments was our interest in a brief intervention for BPD arose as a means of addressing some consumers' preferences for shorter interventions and also the possibility of responding differently emotionally within the first few weeks of treatment. As I've also highlighted, Wise Moments was also conceived of as part of the STEP care model. So the research particulars, we had 56 people completed Wise Moments. The majority of participants were female, as you can see, with a mean age of about 34 years. The best score, the best is a measure of symptom severity at baseline was 42, and the range of scores on the best that are possible are 12, which is least severe, to 72, which is most severe. There's no actual guidance in the literature about how to characterise a score of 42, but I would probably characterise many of the participants in this project as moderately severe to severe in terms of their experiences of BPD. We used a range of measures to assess the intervention, as you can see: symptom severity, psychological flexibility, mindfulness, self-compassion, and psychological well-being. And to our great interest and, I guess, pleasure, really, there was statistically significant improvements on all clinical outcomes at discharge following the completion of the Wise Moments program. So this would suggest, I think, that a brief intervention for BPD can be highly effective. An ACT treatment-based intervention over 4 sessions can be highly effective. I also think that it might suggest that clinicians consider an initial focus on observing painful thoughts and feelings, and that principle of actually using the observer self to step back early in treatment so that there's a different experience really upfront for people. I think that's important in terms of retention in treatment, but also just changing the experience people have of their emotions and their thoughts really early in treatment. Another very, very important aspect of this intervention was the experiential focus. There was a focus on present moment awareness in session. So that meant actually experiencing stepping back from thoughts or noticing what was happening emotionally in the session and then reflecting on that. That process in session was significantly supported by tailored home practice. There was a home practice booklet, but that had a range of options for how that might be used, and different participants took that up in different ways, I believe. You know, some of the home practice worked really well for some people, less well for others, and vice versa with the different practice formats. And I guess in terms of future challenges, a key limitation of the study is it was conducted in a specialist BPD service, which is a strength of the intervention in the sense that very, very experienced clinicians, Clive and Tanya, designed the intervention. And that's, I think, reflected in the pretty amazing results that we've found. But at the same time, future challenges might involve testing Wise Moments within a more generalist setting. So that's where we hope to take Wise Moments in the future. Thank you.
Thank you very much, Fiona. That is a remarkable outcome for a 4-session intervention, and I think it reflects beautifully the astuteness of clinical understanding, perhaps, of some of core difficulties that are facing their clients. They can tailor it in such an effective manner. It's also an example of interested clinicians, research-interested clinicians, setting up and evaluating novel treatment programs, which is happening quite a bit at Spectrum. All right, so I'd like to introduce now our next rapid fire presenter. It's my colleague, Dr. Dervila Gek. And Dervila is a senior clinical psychologist and accredited MBT practitioner. She has experience working with complex clients in community mental health and forensic settings. At Spectrum, Dervila works on the MBT and complex care teams, and the title of her presentation is Intensive Group Intervention, a population-based treatment approach.
Hi there, my name is Dervla Gak. I am here to tell you a little bit about a 10-week group program that we ran at Spectrum in 2016 to 2018. And the program was really a pilot study. It was aimed to look at whether a brief, condensed treatment would be efficacious. And if so, would this make a case for making psychotherapy more accessible and affordable for people? So the background to our study, there are many specialist therapies such as DBT, MBT, schema-focused therapy that have represented a major step forward in the treatment of BPD. However, for many people, these treatments are inaccessible due to the expense in resourcing and running these programs. So recent literature has also highlighted in looking and comparing really specialist treatments with generalist treatments, and find that each treatment really performs quite similarly. And this was something that Troy Kane identified in her review of the literature. This program is also based on the work of John Lively, who suggested that it may be possible to develop an integrative approach to BPD treatment. So that would be combining technical eclecticism with common factors treatment approaches. So really then taking specific aspects of specialist treatments, basing on a general common factors treatment framework. So the IGP program basically aimed to do that. It was a pilot study to develop a skills training group based on common factors treatment and incorporating elements of specialist treatments for BPD. So as I said, we aim to deliver this over a relatively brief period of time, and we hope this would improve accessibility to treatment in the long run. So we could only really find one study in the literature, the STEPS study, that was similar to our study. And this was pioneered by Nancy Bloom. The STEPS study was based on a cognitive behavioral approach. It was a 20-week program with 2-hour group sessions. And it found that after 1-year follow-up, the researchers found that it was effective in reducing BPD symptoms and improving quality of life. So I'm not going to go through the specifics around common factors treatment approach, but here's simply some factors that we think are common to most treatments and are what it maybe is of value in most treatments. Our program itself had the common factors in it. We also had elements of specific treatments such as mindfulness, emotion regulation skills, a focus on sense of self, a focus on relating to others. So you can see here there's DBT, there's ACT, there's MBT, there's self-compassion therapy intertwined. Our program was intense. As I say, it was 2 days a week for 10 weeks, and each session was 4 hours in length. We had no individual sessions, and there were 4 to 6 participants in the group with 2 facilitators. And the majority of our referrals came from the Spectrum Mac Clinic. And our assessment was really focused on whether the individual had the capacity to participate in a group treatment, because essentially really, if a person would be very triggered or become very overwhelmed by there being a lot of minds in the same room, this really wouldn't be a suitable treatment for them. Our program was evaluated using a range of outcome measures. We looked at self-harm and suicidality, and we also looked at participant feedback. We administered these questionnaires at baseline. Time 2 was immediately after the 10-week program, and time 3 was 4 to 6 months after the program. We assessed 88 people and we offered 58 people a place. So there were 30 people we didn't offer a place, but I think it was 16 of those actually withdrew themselves. And then 44 of the 58 people that we offered a place actually completed the 10-week program. So only 6 people in this cohort actually dropped out because they were dissatisfied with the program. The remaining people, there were psychosocial issues or other health issues that prevented them from attending. So this is a summary of our outcomes at time 2, and we do find significant effects on all of our measures except for our social functioning measure. We had a large effect size in terms of BPD symptomatology, with moderate effect sizes in the other measures, which were emotion regulation, general health, depression, anxiety, self-compassion, and anger. At time 3, we had, we really had it as with small cohort, only 12 people that we were able to follow up. But we did find in this group that there was a maintenance in those clinical improvements. We particularly find that self-compassion and general health, so there were positive effect sizes associated with that at the 1% level. For the other scales, there was a significance at the 5% level, and there were moderate effect sizes associated with those changes. Unfortunately, we couldn't actually compare the rates of self-harm and suicide at time 2 and time 1, but I just put these up here, these figures up here, so that you can see that, I guess at the end of treatment, there was a very small number of people who were engaged in suicidal behaviour. And when it came to self-harm, we had about 40% who were still engaging in suicidal behaviour. Our participant feedback was quite positive. We had 70% report the programme had improved their knowledge of BPD, 70% reported they thought the programme had helped them deal more effectively with their difficulties, 59% thought the programme met their treatment needs, and 92% were satisfied with the programme. Of note, the dropout rate was actually below average as well. So to conclude, we find that there were moderate to large effect size changes associated with most of our outcome measures at time 2. This was actually very similar to the research done in the Blum in the STEP study. And Blum found that there was a large effect size change in BPD symptoms, a moderate effect size change in depression at 1-year follow-up. And for us in this study at time 2, which was 4 to 6 months later, we were found that for the cohort that did come back, there was a maintenance in the clinical improvements found. Notably, social functioning did not change, and this really has been echoed in many research studies. For example, the collaborative longitudinal PD study reported persistent ongoing social impairment over the course of a 10-year follow-up. So this really does beg the question, are improvements in social functioning much harder to really attain than reduction in symptoms? A brief note on the cost analysis. A review by Meldrick suggested that running a DBT would cost between $8 and $27,000 US. Our program, the IGP, was $1,500 US costing. So our implications: this pilot study does support the proposition that brief treatment programs that use a generalized integrated approach to BPD treatment may be a viable option. Such programs may increase the capacity of mental health services to meet the needs of a larger proportion of people who experience BPD, and it's likely that briefer treatment programs of this nature are well suited for the inclusion within a stepped care model. And thank you very much.
And thank you, Dervla, for walking us through one of Spectrum's effective and innovative treatment programs. One of the encouraging aspects of that, apart from the fact that it seems to work for a lot of people, is that it doesn't require specialist training for the clinicians who would like to facilitate this program. If you have questions or you'd like more information about that, in the chat there you can see there's a spectrum.research email address. You're welcome to put requests, questions through there as well, and they'll be answered after the forum. So our next rapid fire presenter is Associate Professor Sathya Rao. And Sathya did introduce himself earlier, albeit rather modestly. He's a psychiatrist. He's the Executive Clinical Director of Spectrum Personality Disorder Service. He's a Vice President of the Australian BPD Foundation and an Adjunct Clinical Associate Professor at Monash University. He's probably, his ears are burning right now. He is also currently a deputy in the Office of the Chief Psychiatrist. How he does all of these things remains truly a mystery, but his work is inspired and highly influential in the field. Associate Professor Rao engages in clinical research and has published papers, contributed chapters, and co-authored books on personality disorder. The title of his presentation today is Feeling Suicidal to Survive, a Personality Disorder Audit Using the Victorian Suicide Registry.
Today I'm presenting the Victorian Personality Disorder suicide data for the investigations that we did with the Coroner's Suicide Registry. As you are aware, recurrent suicidal behaviors, gestures, or threats, or self-mutilating behavior are diagnostic criteria for borderline personality disorder. And as such, chronic suicidality is a signature symptom of borderline personality disorder. The suicide rate for borderline personality disorder is 10% globally. 90% of patients make suicide threats or gestures. 65 to 70% attempt suicide at least once in their lifetime. As the Canadian expert Joe Paris puts it, suicidality can be seen as a coping strategy. Most don't go on to end their lives by suicide. Herein lies the paradox. The only way for them to go on living is to maintain the option of dying. For most people with borderline personality disorder, life feels so painful that they feel half in love with death. BPD patients can often tolerate distress only if they know they can escape it by suicide. They feel suicidal to survive. Coming to our study, the primary aim of the study was to describe the socio-demographic characteristics of people diagnosed with a personality disorder who died from suicide in Victoria. The secondary aim was to describe the health profile, external stressors, and service engagement of these individuals. We utilized the Victorian Suicide Register to identify suicides occurring between 2009 and 2013, where evidence of a BPD diagnosis was recorded. Our study describes a population-based analysis of coroner's investigations of suicides where there was evidence of a BPD diagnosis. Of the 2,870 suicides during this period, 181, that is 6.3%, had a BPD diagnosis recorded. Evidence of other personality disorders was also recorded in a very few individuals, 14 of them, that is about 0.5%. And in a further 72 people, BPD was suspected by looking at the clinical notes. Information coded in 181 diagnosed BPD suicide was compared with the 2,689 suicides without a BPD diagnosis. Now, compared to the no BPD suicide group, the BPD suicide group was younger, had greater diagnostic complexity, that is comorbidity, had a higher proportion of death by drug overdose, and a higher proportion of social and contextual stressors. As you can see from this table, a greater amount of coexisting psychiatric disorders were noted in BPD group as compared for non-BPD group. This graph also demonstrates that the BPD group was significantly more younger compared for non-BPD group. So our study found that on an average, there was one BPD related suicide per week in Victoria alone. So this is what was most striking for us. That is 99% of the people who died by suicide with a diagnosis of BPD had passed through public mental services in the preceding 1 year. 88% of them had made contact with public mental services in the last 6 weeks. 25% of them had made contact with emergency departments in the preceding 6 weeks prior to death. So they're clearly seeking help before suicide. This is a rather busy slide and a busy table, but what it shows is that 95% of PPD-related suicide seems to occur in adults between the age of 18 to 64. And nearly 80% of the suicides occur in adults from 25 to 64 years of age, with small numbers in under 18 and over 65. So this data is, of course, not new, and it has been shown in the literature that age when suicide behaviors are most prominent in people with the diagnosis of borderline personality disorder is usually in their 20s, and the average age of death by suicide for BPD is 38.3 years. So in summary, about 10% of all suicides for all reasons is for a diagnosis of personality disorder, mostly borderline personality disorder. There is at least one BPD-related suicide per week in Victoria, and men and women are equally represented in death by suicide. There is significant co-occurrence of substance use disorders, police involvement, or legal issues in relation to BPD suicides. Also, most are seeking help from public mental health services. So in conclusion, in the Victorian context, it is evident that people with borderline personality disorder are seeking help from public mental services prior to suicide. And this study highlights a critical window of opportunity for providing timely support and treatment to help avert future deaths. That should be the focus of the next research activity for us. Thank you.
And thank you, Professor Rao, for that sobering and thought-provoking presentation. And while it's kind of, I know looking through those files, it was difficult to go through and collect the data for that study. There have been some truly great outcomes from it in terms of funding for more resourcing in personality disorder. So, and the other thing too is that we've confirmed the international numbers for our Australian context. So Dr. Lucas Cheney is our next presenter. Lucas is a consultant psychiatrist at Spectrum and has training in dialectical behaviour therapy and mentalisation-based treatment, and a keen interest in research that will improve our understanding of personality and associated disorders. Lucas' talk is entitled Neurodiversity and Personality Disorder.
Hello, everyone. My name is Lucas Cheney. I'm a psychiatrist at Spectrum and also a DBT practitioner. And today I'm going to be talking about the concept of neurodiversity and how it may relate to personality disorders. I'll start out by giving a little background about my interest in the area. I've been treating a person with autism and borderline personality disorder for about the last 2 years. And in working as a therapist with this person who's been diagnosed with all 4 of BPD, autism spectrum disorder, autism, ADHD, and cognitive impairment, I found it's often very difficult for people who do not know her in depth to understand how she experiences the world and to recognize her cognitive strengths and relative weaknesses. This complexity makes a standard approach to personality disorder less effective than a multidisciplinary approach. The other reason I'm interested is because our service has also noted an increasing frequency of referrals for people that have diagnoses of autism, ADHD, and cognitive impairments of varying degrees, and that these diagnostic categories and others have been suggested to fall under the umbrella term of neurodiversity. What is neurodiversity? Well, it's a term that was coined in 1998 by an Australian sociologist by the name of Judy Singer. She and the people that have been advocates of this term have created it to promote a view of certain stigmatized diagnoses as disabilities needing support, as opposed to disorders needing treatment. And the term refers specifically to variations in a number of different cognitive domains, which I have listed here. What started with autism has spread to other developmental conditions. These variations that are represented by the terms on the slide are relevant for a significant proportion of the population. It's estimated that the Australian population of autistic people alone is somewhere around the populations of Canberra and Darwin combined, totaling about 500,000 people. Since the term neurodiversity was coined back in the late 90s, advancements in the understanding of the brain have given neurodiversity new meaning. Freud and contemporaries pioneered the idea of the unconscious, but the cutting edge of research in brain science these days suggests that we have even less control over our experience of reality than we thought. So cognitive scientists like Professor Anil Seth here propose that consciousness is a controlled hallucination. What Prof. Seth means is that the brain is not as simple as information in and consciousness out, like a calculator giving results. The brain is more like a weather map, which is taking in huge amounts of data and then offering a prediction that is limited to the information that's relevant to your specific needs. So if you take this image as an example, this represents a huge amount of information that's been collected from an immensely complex system. But the image distills it down to just what you need to know so that you can decide if you need to take an umbrella to work today. And in a nutshell, that appears to be what the brain is doing all the time. It's making predictions that are relevant to your needs. An example of the brain predicting and interpreting information is the shade illusion. You can see here that there are two blocks that are actually the same shade, but that one appears a different color when it's in the shade of the large object on the left. The leading theory is that your brain turns up the brightness of the color perceived to adjust for the low ambient light in the shade. The important point is that your brain is changing your conscious experience without you having any control over it. Another well-known example that's related to the shade illusion is the viral dress photo. About half of people see this dress as blue and black, while the others see it as white and gold. Again, the theory is that variation between individuals about the ambient light that is hitting the dress. Some brains assume more blue light, some more yellow light. And so the brain adjusts the colors so they are perceived differently. The point here is that we cannot tell if we are having the same experience of reality as someone else unless we check. So why might this be relevant to personality disorder? Well, we know already that there's been research that's established that there are high rates of traits of ADHD and autism in people with BPD, and that when those traits are present, there's often increased risk of suicide and often reduced response to the standard treatments. And this figure at the bottom here is from a study in 2007, which found that up to 80% of people presenting to mental health inpatient and community services had impairments in their ability to understand nuanced speech and language, and that these impairments were unknown before they were tested for specifically. So there's active discussion in relevant communities about the extent to which these various terms and diagnoses that you can see here may represent forms of neurodiversity. I'd like to highlight that trauma is among those areas in the top right, which some suggest may lead to an altered perception of reality. So discussion of the relevance of neurodiversity for diagnostic issues is certainly an important thing to consider. But I think that there's actually another potential of this concept because it allows you to actually measure cognitive domains that might underlie the challenges that people are experiencing. So this image shows the potentially relevant neurocognitive domains that you might look at when you're studying neurodiversity in an individual. I chose to focus on the 4 domains on the left in this figure as an initial investigation into the possible presence of neurodiversity in people with complex and severe presentations of personality disorder. So I'm going to focus on these 4 domains in the next slides. So the challenge was to choose measures which are easy to administer, but can give some initial insight into these cognitive domains. The first one that I started using was the TACIT. This is a series of videos which tests a person's perceptions of emotions and motivations in social interactions. The second is the Montreal Cognitive Assessment, which is a broad and general screener for multiple areas of cognitive function. And the third is a brief self-report screener for symptoms of ADHD. So here are the results from administering these measures in about 25 people. The takeaway from this is that anything you see that's blue represents impairment according to the test that was administered. It's important to note that this is a biased sample because we gave them to people for whom we suspected there might be an issue. Also, the ADHD measure is different from the others because it's a self-report of symptoms, whereas the others are more objective measures of performance. It's also important to note that strong performance in the cognitive test did not always mean strong performance on the social inference tests and vice versa. So even with this small and biased sample, these results appear to pose some interesting questions. The first one to me is, does this mean that people's conscious experiences are potentially as diverse as our identities? Is it possible that everyday experiences, which one person may take for granted, may be difficult or impossible for another without us knowing? Do certain forms of neurodiversity make someone vulnerable to developing personality disorder symptoms? Can we systematically uncover and understand neurodiversity as it relates to mental health? And is it possible that there are some clinical markers of neurodiversity which might help to guide prognosis and treatment decisions? So, and the final question for me, we know already that the relationship between insecure attachment, trauma, and personality disorder has been well established. But is it possible that there's a third major etiological factor which may lie within neurodiversity? Thanks very much.
I'd like to thank him very much because this really defines an important step towards understanding people as complex individuals and developing patient-centered diagnosis and treatment. I think we will watch this spot, Lucas. You're onto something big here. So I just want to remind everybody that although these rapid fire presentations are pre-recorded, the speakers are standing by. And so if you have comments and questions, put them in the Q&A and they will respond to them in real time. And after the break, we will have what we call live presenters again, and with an opportunity for sort of more collaborative Q&A at the end. So we're halfway through our rapid fire presenters. It's now my pleasure to introduce Dr. Mithra Nithyanandan, who's a consultant psychiatrist at Spectrum. And Mithra has a particular interest in optimising the ways that we work with BPD in primary care settings. She will be describing her scholarly research project entitled Confidence of Psychiatry Trainees in Diagnosing, Supporting and Treating Borderline Personality Disorder.
Thank you for joining me. Today I'm presenting a study we published in Australasian Psychiatry earlier this year, looking at whether psychiatrists are being adequately trained in BPD. A very brief update on BPD to start. Many of us are aware that BPD is associated with severe functional impairment and medical comorbidity. People with BPD have a 20-year reduction in life expectancy and around 10% of patients suicide. It's clear that BPD is a major public health concern. Reassuringly, we can be very optimistic about BPD. We know symptoms are responsive to psychotherapy treatment and that with treatment, most patients achieve remission within 2 years. We're all aware that specialised treatments such as DBT and MBT are effective. But what may be less commonly known is that generalist or common factors approaches appear to be equally effective for most patients. The current public mental health system primarily plays a role in crisis intervention and hospitalisations, but there's no evidence to suggest that admissions prevent suicide or assist with recovery. So the best risk management strategy we can offer is psychological treatment. Unfortunately, however, most patients don't receive this from services. We don't have much Australian data regarding psychiatrists' approach to BPD. Studies from the UK and US suggest that despite all of the reassuring evidence we have about prognosis and treatment, psychiatrists' attitudes have unfortunately remained negative. Most psychiatrists aren't familiar with delivering BPD-specific treatment, and this appears to result in a reluctance to diagnose BPD, and it may contribute to perpetuating stigma and therapeutic nihilism. There's also a tendency to refer most patients with BPD to specialist services, and this seems to suggest a perceived lack of skill in providing treatment. The literature raises concerns around training, psychiatrists' attitudes, and service provision in BPD. For our study, we wanted to investigate the confidence of Victorian trainees in the assessment, management, and treatment of BPD. In order to gather more robust data, we wanted to compare confidence against another major mental illness. In our study, we chose schizophrenia as a comparator, as it has similar prevalence, morbidity, mortality, and burden of disease to BPD. For our study, we developed and piloted a self-report survey, which was distributed at 5 major metropolitan health services in Victoria. The survey questions asked trainees to rate their confidence and competence in BPD and schizophrenia using a 5-point Likert scale. As you can see here, each section pertained to a specific area of the training: diagnosis, developing a management plan, managing suicide risk, delivering treatment, and prescribing. Trainees were also asked to rate their willingness to work with clients with schizophrenia and BPD after receiving fellowship, and they were asked whether they felt their training and supervision for each disorder was adequate. We had 82 trainees complete the survey, so that's almost a quarter of the entire trainee population. And we recruited about 1/3 of trainees who were in their final stage of training. So that's quite a good response rate. The results were clear in showing that trainees were significantly less confident in the assessment, management, and treatment of BPD compared with schizophrenia. And this was consistent across all 3 stages of training. This busy table outlines our results. The size of the difference between schizophrenia and BPD is indicated by the Z-score. As you might expect, the biggest difference in confidence was in delivering treatment, where trainees were far less confident for BPD. This was particularly notable in final stage trainees. There were also considerable differences in confidence in relation to developing a management plan, managing suicide risk, working therapeutically with clients, and prescribing. Here we looked at the 9 trainees who had accessed additional training in BPD-specific treatment. And as expected, those who'd received this additional training were far more confident in working with BPD than those who hadn't received training. This slide looks at trainees' willingness to work with patients diagnosed with BPD or schizophrenia after finishing their training and becoming fellows of the College of Psychiatrists. Concerningly, stage 2 and 3 respondents reported a significantly lower preference for working with BPD clients compared with schizophrenia. Almost 40% reported inadequate supervision in BPD, and almost half reported inadequate training in BPD. Almost half of stage 3 trainees specifically reported inadequate training in BPD. In contrast, almost no respondents reported inadequate training or supervision in schizophrenia. While developing this study, we weren't certain whether trainees felt treatment for BPD was part of their core business. In our study, most trainees actually expressed a strong desire to learn skills so that they can treat BPD. They want to feel confident in working with BPD. Notably, many felt that a lack of training had left them feeling incapable of treating BPD clients, and a few highlighted that they felt they couldn't offer much beyond crisis management. Many highlighted the systemic barriers which preclude them from any exposure to longer term work with BPD clients. And this is unsurprising given that the public mental health system is geared towards a crisis response model for BPD. Trainees don't get an opportunity to see clients with BPD remit or recover. So we can understand why there may be a sense of therapeutic nihilism amongst trainees when it comes to BPD. To improve training in BPD, trainees suggested access to more psychotherapy supervision, training in BPD-specific treatment, more opportunities to work longer term with BPD clients, and more specialist rotations, such as what is offered at Spectrum. Notably, only 2 respondents out of the whole cohort made any suggestions in relation to schizophrenia training. Based on our findings, we can see that trainees are clearly less confident and concerningly less willing to work with BPD compared with other major mental illnesses. And it looks like deficiencies in training and supervision play a major role in this. Trainees want to learn how to treat BPD and they haven't had routine access to training, however. We know that it's probably unrealistic to expect all trainees to become competent in specialised treatments such as DBT, but it is probably feasible to provide routine training in a generalist or common factors approach. We all know there are a number of specialist treatments which have an established evidence base for treating BPD, and there are Australian contributions which are still gathering evidence. To reiterate, there are a number of generalist treatment modalities which are just as effective as specialist treatments, and this is probably because there are more commonalities than differences between treatments. General psychiatrists can absolutely treat BPD, and we should be instilling this confidence and optimism in our trainees. This quote from John Gunderson captures this sentiment. With effective training, most clinicians can effectively treat most patients with BPD. I've outlined here some limitations we identified when conducting the survey. In particular, there was a possible lack of generalisability due to the survey being only conducted in Victoria. Some concluding remarks to finish. We know BPD is a severe mental illness with significant public health impact, and psychiatrists should play a core role in addressing this. Victorian trainees feel less equipped to work with BPD in comparison with other major mental illnesses. We know generalist treatments work, and they can be delivered by general psychiatrists. Training is available through resources such as Spectrum, but our trainee psychiatrists do not have access to routine training, and they aren't exposed to longer-term work with BPD. Improving training and instilling confidence in trainees is vital to ensure we have an adequate psychiatric workforce for addressing the needs of people living with BPD. Thank you very much.
We all want to thank Dr. Nithya Nandan for sharing these really important insights. I just want to reiterate that was a scholarly project that Mithra did as part of her psychiatry traineeship. So it's shining a spotlight back on the training program. So I hope people are listening, and there could be more opportunities for the psychiatrists coming through to have exposure to actual treatment and being able to observe longer term what happens to people suffering from BPD in mental health services. It's a pleasure now to introduce my research colleague, Dr. Aghareed Al-Kassab. Aghareed was appointed as a research fellow at Spectrum earlier this year and has already had a huge impact on our evaluation program. Prior to this year, Aghareed was engaged in a distinguished research and teaching career in paediatric oral health. The title of Aghareed's presentation is Preliminary Findings from the Spectrum Evaluation Program.
Hi, this is Aghareed. Today I'm going to present a preliminary findings for the Spectrum Service Evaluation Program. The Service Evaluation Program was introduced by Spectrum in 2016 to facilitate external reporting and quality control processes. It's considered as part of the client care to identify treatment needs and optimize the care provided for the client throughout the treatment course. It's also used to utilize the outcomes for clinical research and publication. So how does the program work? The program was conceptualized to be inclusive of all clients admitted to Spectrum treatment program, which included the 4 BPD clinics. The program consists of a set of measures which were designed to be carried out longitudinally as part of routine care of clients admitted to a spectrum treatment program. The frequency with which the measures are planned to be administered is as the following. During initial assessment, and then once treatment commences at 6 monthly intervals until discharge, which could be at 18 or 24 months, and then at 12 and 24 monthly post-discharge follow-ups. The evaluation package consists of a set of measures, 3 of which are administered by the clinician, and is represented by the SCID, ASSIST, and the SASH tools, and 6 are self-reported and represented by the BEST, the eating disorder, the depression, social adjustment scale, emotional regulation, and personal well-being measures. So the self-report measures in general are used to assess a number of areas where difficulty is commonly experienced by individuals with BPD. For both clinician and client administered measures, both paper-based and web application, which is the REDCap, web-based application are used to make it more convenient to the client and the clinician as well as to increase the participation rate. So in this slide and the next slides, I'm going to present the outcome, the evaluation program since its establishment. Descriptive analysis and repeated measures analysis were used to assess treatment efficacy of the program for all clients from initial assessment through to discharge phase. The majority of the clients are females with a mean age 33 years. Of the total 238 clients, there were 123 who managed to complete at least one evaluation phase. Of the total, 40 clients are on the waiting list and 36 were dropout prior to clinical discharge. 7, they failed to attain an evaluation phase, and a further 32, they supplied incomplete responses. So all these were excluded from the analysis. The personality disorder categories were assessed using the SCID interview. Overall, there was a clear reduction in the mean scores, score values of all types of personality disorders. Diagnosis of avoidant, depressive, paranoid, schizotypal, and borderline personality disorders were statistically significantly reduced at discharge as compared to the baseline evaluation. The frequency of substance use by clients over 3 time points are described or shown in this figure. Although not statistically significant, there was a substantial reduction in the consumption of all harmful substances except for tobacco. So as we see, there was a medium positive correlation between smoking and evaluation period of time, and as there was a steady decrease in smoking or tobacco use as we progress in the evaluation treatment. So this would be explained like could be negatively correlated with a significant fall in prescription sedative use and decrease in the consumption of alcohol, which may in part explain the increase in smoking, as we know, because tobacco would have like anxiolytic effect. The borderline evaluation of severity over time, which is known as BEST, aims to evaluate symptoms of BPD by characterizing the thoughts, feelings, and negative behaviors, as well as positive behaviors. At discharge, the clients reported less severe thoughts and feelings associated with BPD. They reported less difficulty with negative behaviors as well, such as difficulties with self-injury or suicide attempts. Improved positive behaviors were also endorsed throughout the course. And as we see here, total scores on the best as well as scores of all subscales were significantly reduced during the discharge evaluations, suggesting improvement at discharge. Also, clients completed the Big Depression Inventory Questionnaire, which aims to assess the presence of symptoms of depression and, where present, characterize the level of symptom severity. In the initial evaluation, severe depression was featured, whereas depression remarkably reduced as evaluation progressed, and reported or showed moderate to mild depression was found at the end of the evaluation. Clients also completed the eating disorder examination questionnaire, which identified symptoms of disordered eating and has 4 subscales. These are restraint, eating concern, shape concern, weight concern, and weight concern. And while clients reported difficulties with restraint, avoidance of eating, and almost daily concern regarding their shape and weight at the beginning of the assessment, there was a significant reduction in these concerns at the end of the evaluation. Similarly, with the social adjustment scale self-report, which was used to assess adjustment in social rules, including performance on expected tasks, interpersonal relationships, and feelings of satisfaction. At the late phase of the treatment, clients' responses suggested that relative to the general population, their performance and satisfaction across these life roles is normal. And finally, clients were asked to rate their satisfaction with various aspects of their life on Likert scale using their personal well-being index. Their overall satisfaction has improved with particular improvements in their physical health, personal relationship, and standard of living. However, despite these significant improvements, satisfaction with life as a whole was still below that of the average population. So in conclusion, despite the uneven distribution of the scores and despite the different completion rate that we noticed throughout the different evaluation phases, there was no differences observed among the different specialist treatments, and we believe that the current findings robustly support the efficacy of a range of PPD-appropriate psychotherapies for promoting clinically significant improvements in psychiatric symptoms and quality of life in patients with severe and complex personality disorder. Thank you for listening.
And thank you, Dr. Akasab. You've done an amazing job joining us this year and wrangling our evaluation program to make sense of all the data that we've been collecting. So it's fantastic, and it's an exciting bit of work and supports the efficacy of Spectrum's treatment programs across many important endpoints. Our next rapid fire presenter is Dr. Nithin Dawadkar. He's an accredited psychiatrist at the Melbourne Clinic, which is actually next door to Spectrum. He is an adjunct senior lecturer in the Department of Psychiatry at the Central Clinical School at Monash University. Additionally, Dr. Dawadkar is a foundation member for the Faculty of Forensic Psychiatry and the Royal Australian New Zealand College of Psychiatrists. The title of Dr. Dawadkar's presentation is Telehealth and Wellbeing During COVID.
So I've been asked to talk about telehealth and well-being during COVID. This was a research project which had started last year, in the middle of last year, by the research team at Spectrum, which is a service for personality disorders in Richmond, Victoria. Just to introduce myself, and this is to introduce the researchers and authors from Spectrum: Gillian Broadbear, Pari Hadari, Lucas Cheney, and Satya Rao. So we'll start by talking about the well-being of clients section of this study. So the impact of COVID-19 lockdown on the well-being of clients of Spectrum. So this is a demographic to just let you know the gender kind of distribution. There were, of course, 86% females, and the rest, most were males. These are some of the open-ended questions concerning various aspects of health, which were asked of both clients as well as the clinicians or providers of the mental health service. We'll come to that in a minute with the results. So the objective really of the first part was to investigate the well-being of people with severe borderline personality disorder during the first wave of the COVID-19 social restrictions in 2020. So the method, the clients of this outpatient specialist personality disorder clinic, 77 were invited for the study. It was an online study, included open-ended questions, as well as included the CAS scale, which is the coronavirus anxiety scale. And the qualitative data were analyzed using several softwares, including the SPSS version 25. Finally, we got 48% response rate, which was 36 surveys. Many of the participants appeared to have experienced significant challenges to their overall well-being during the lockdown. However, some reported improvements in psychosocial functioning, and 3 out of 36 clients participated had a CAS score of more than or equal to 9, just letting us know that there was dysfunctional anxiety related to the coronaphobia. So with the sleep results, the quality of sleep, 14 out of 29 experienced insomnia or worsening of quality of sleep, and 44% in fact reported that their sleep was quite unchanged. Relationships with cohabitants, 18% said their relationships with cohabitants had deteriorated. About 26% reported that their relationships were stable. And in fact, 11% reported an improvement in relationships. And one of the poignant statements or responses was from a client was, "I think COVID-19 has brought us closer together as we have more time to spend together." Relationships with non-cohabitants, 12 out of 30 respondents reported it was more challenging during the restrictions. This is with the wider contacts outside the home. And 23% maintain relationships, though, with phone calls or texting, while 10% said that their wider relationships also remain stable. With the CAS scale, or the coronavirus anxiety scale, 3 out of 36 clients had a score of more than 9, suggesting that they were experiencing quite moderate to severe coronaphobia. Overall, it appeared from the results, or a conclusion was made by the researchers, that the clients demonstrated resilience, which it suggested that the capacity to maintain treatment via telehealth helped to reduce many of the adverse effects or aspects of the social restrictions. And initially, the expectation was that the social isolation would be particularly challenging for people with borderline personality disorder. And although many did experience considerable challenges to their overall well-being during the lockdown, probably an unexpected finding was some participants reported improvements in their psychosocial functioning. And in fact, the majority of participants had a positive relationship with the people with whom they lived. The provision of BPD-appropriate psychotherapy via telehealth did attenuate some of the most concerning expressions of BPD, suggesting significant benefits of telehealth psychotherapy, at least for that short term of period when the study took place. Going to specifics about the Australian clients or consumer experience about telehealth platform for psychotherapy, there were positive and negative experiences. Read the effectiveness of telehealth. About 32% of the participants were unsure, and 19% were quite not interested in telehealth following the pandemic, obviously preferring face-to-face, while 50% acknowledged that the presence of telehealth actually was positive, and they wanted to have that option even following the pandemic. And almost every client continued to attend appointments. And as I stated just earlier, 50% of participants wanted this option of telehealth going into the future beyond the pandemic. Coming to healthcare providers and the impact of the COVID-19 lockdown on well-being of the clinicians and providers working in a specialist clinic for personality disorder. In total, 39 surveys were completed and the response rate was very high, about 93%. The negative changes were reported as being loss of social interactions with the wider family and friends, which was the most challenging aspect of lockdown. 2 participants experienced coronaphobia in the initial pandemic restrictions. The other negative changes were being less fit, 18%, pain in the neck, shoulder, and back, 18% again, weight gain about 13%, and fatigue with vision about 5%. There were several positive changes for about 19% of the people. They reported a better work-life balance. Of course, absence of the work commute helped a lot to make more time available with family and for self-reflection. And in fact, one of the responses was, I actually feel calmer. I think having less distraction has been good for me. Also, there were positive changes in physical activity levels by at least 21%. The quality of sleep, majority reported positive changes to sleep pattern. However, for 10 participants, they reported a worsening of sleep quality. Again, the self-reported health of the providers demonstrated resilience, which also suggests capacity to conduct therapeutic work via telehealth from home did reduce and mitigate several adverse effects of the pandemic-related social restrictions. Relationships with cohabitants and non-cohabitants, out of the 37 respondents, a large proportion had positive experiences regarding their relationships with the people they lived with. One of the responses was, it's nice having so much time at home with my immediate family and knowing that we can do things together. It is nice that we aren't rushing around on the weekends and can have more quality time. The challenges and benefits continuing on, the most commonly reported challenge was loss of social interactions with family and friends. Of course, this is the wider family and friends outside the home. Some of the other statements and responses on questioning was, I'm very grateful this pandemic has come at a time where telehealth is a feasible alternative to face-to-face work. I'm happy to avoid spending a couple of hours each day commuting to and from work. And one more, it's nice to have to wear uncomfortable work clothes. And finally, I'm very glad the natural world is experiencing a brief reprieve from carbon emissions and other forms of pollution. So the specific experiences regarding the platform of telehealth psychotherapy revealed that despite some initial technical issues, most of the clinicians rapidly and very successfully connected and performed telehealth psychotherapy with clients. Appointments were kept far more reliably than when in person was offered pre-pandemic. A range of issues were raised about risk, confidentiality, privacy, interaction, quality, highlighting the need that future studies and guidelines need to be implemented. Overall, though, it was an acceptable platform and can be managed safely for treating patients with severe mental illness. And most of the clinicians were looking forward to using it into the future beyond the pandemic. Of course, limitations of the research study were that the study was conducted where the clients opted in, potentially introducing some bias, and data was collected using an online survey with a cross-sectional design. And hence, subsequent studies would be indicated to reveal longer-term effects of this kind of a telehealth psychotherapy policy. Finally, conclusions beyond the pandemic. Important to evaluate the long-term relative outcomes, effectiveness, and safety data via larger samples of similar studies and longer duration of the study. and of course, telehealth service training specific for telehealth psychotherapy guidelines to be prepared. IT training and resources for clients and staff would be indicated going forwards. And just to remember that telehealth may not be appropriate for some individuals and some clients with severe mental illness, with active psychosis, active suicidal ideation, or situations where a higher degree of confidentiality is critical, or where the IT skills or devices are just not available for the clients. So finally, telehealth is not a panacea. It requires tailoring for every client, and depending on the tailoring, it needs to be deemed either appropriate or not appropriate. And finally, beyond the pandemic, telehealth could be complementary to existing face-to-face care. Of course, more work and research needs to be done, finding out for more evidence which is required how telehealth psychotherapy can really integrate with face-to-face mental health care. All the researchers thank all the participants of the study, the clients and the clinicians who participated for their time in completing the survey. And finally, thank you all.
Thank you, Nitin. I think we can all recall a certain sense of anxiety, trepidation as we headed off into the unknown with the first national lockdown in March last year. This was a huge uncontrolled experiment, of course, and conducting these surveys of our clients and our clinicians really helped to capture some of the experiences during those first weeks. I think probably time has shown, and successive lockdowns, some of the limitations of the telehealth model in terms of extended treatment, but it certainly was a life-saving intervention. And I think it took about a week. So within a week, Spectrum clinicians had transferred over to telehealth and continued contact with their clients. So it was quite an exceptional time. So thank you very much to Dr. Dawadkar. So it's a pleasure now to introduce another of my research colleagues, Dr. Pari Hadari. Dr. Hadari commenced working at Spectrum in mid-2019 as a research officer. Pari completed her PhD in the School of Nursing and Midwifery at Monash University. She has been an invaluable member of the research team with several papers to her credit during recent months, including the data that you just heard reported by Dr. Dawadkar. Pari has successfully seen those through to publication. Pari's presentation will describe the Personality Disorder Initiative baseline survey of Victorian mental health clinicians.
Hello, everyone. Today, I'm going to give a quick introduction to the Personality Disorder Initiative, which I'll refer to as the PDI. And the aim of the PDI is to build the capacity in all Victorian area mental health services to assess, treat, and support people with personality disorders. One aspect of the PDI evaluation was to investigate mental health clinician attitudes and knowledge about personality disorder before the initiative began. The main focus of my presentation will be on the baseline survey results for Victorian mental health clinicians. What was the rationale for the PDI? Clinicians' attitudes to personality disorders were found to be less positive than other mental health disorders, and trainings for clinicians are scarce regarding personality disorder. Not all people with personality disorder could have access to the limited specialized treatments. To solve these issues, Victorian State's budget committed $9.16 million over 4 years for the PDI. This initiative will build the expertise and capacity of the clinical mental health workforce to assess, treat, and support people with personality disorder. This initiative is being delivered by 6 public mental health services in partnership with Spectrum. Each of these services designated 1 to 2 clinicians as personality disorder specialists. These clinicians receive intensive training, supervision, and support from Spectrum. Over the course of stage 1, the PDI clinicians began to develop and deliver training within their services to help build the skill and capacity within their workforce to provide more effective support and treatment for people with personality disorder. An evaluation framework was developed in collaboration of the Department of Health and Human Services and participating services to determine whether the PDI was effectively implemented and achieved its intended client, workforce, and system impacts. This was also to identify areas for improvement for future iterations. One important part of the evaluation program was surveying Victoria mental health clinicians working throughout the public mental health sector, pre and post program. The baseline survey was completed by 563 mental health clinicians. I will move on to the findings of this survey. The first chart shows the professional background and gender of participants. As you can see, the majority of participants were female with a nursing background. This pie chart shows a significant proportion of participants worked within community-based mental health services, followed by inpatient settings. Emergency mental health, forensic settings, and residential services were also represented. Service setting included in the other category included education and workforce development and consultation liaison roles. This chart shows years of experience that participating mental health practitioners reported that they had been working with PD clients. As you can see here, participants were highly experienced as both mental health practitioners and in working with clients with PD, with half reporting more than 10 years of experience. This suggests that they have been working concurrently with people experiencing PD from the outset. Among personality disorders, clients with borderline personality disorder were most commonly reported by participants, with the least encountered PD being schizoid. Participants were asked how they perceived that the needs of clients with PD were met by their service. As depicted in the red section of this pie chart, almost half of the participants said that clients' needs were met poorly or even very poorly. Participants reported that clients were more likely to receive treatment or case management if they were frequent users of services such as ED, they had complex and severe presentations, they had suicide attempts, or they persistently requested treatment. In terms of treatment and support options available for clients with a diagnosis of PD, referral to other services was reported by 60% of participants. And the blue bars denoted personality disorder specific treatments. Only 18 to 32% of participants reported that these treatments were available at their service. Only 17% reported having regular or somewhat regular training at their workplace for personality disorder. And the majority, which is 66%, only reported informal and infrequent training and support. As you can see in the right side, 88% endorsed the need for additional training to support their work with personality disorder. And their preference was that this be regular training workshops within your service. This chart illustrates how participants perceive their theoretical knowledge, clinical skills, and experience when working with people diagnosed with PD. More than half rated these as good or very good. 57% of participants rated their experience as good or very good, which makes sense given the majority of participants had more than 10 years experience in mental health and working with people with PD. This chart presents how participants rated their willingness, optimism, enthusiasm, and confidence when working with people diagnosed with personality disorder. It is interesting that willingness is higher than confidence, suggesting that with appropriate training and support, a lot more clinicians will be able to provide support to people with personality disorder. The short 10-item version of the attitude to personality disorder questionnaire was used in the survey. Items asked about the frequency with which these findings were experienced using a 6-point Likert scale. Negatively worded items were reversed scored, with higher scores indicating more positive attitudes toward people with personality disorder. Total score ranges from 10 to 60, and higher scores represent more positive attitudes. The mean score among our participants was 41.2. This was almost identical to a study conducted in 2015 in mental health nurses working at a public health service in New South Wales. And the mean score on that study was 42, which had improved from a low of 38 in the year 2000. These studies show a significant improvement in attitudes toward people with personality disorder compared to years ago, but there is still a lot of room for improvement. This slide shows the experience of burnout in relation to working with people with PD. And as you can see, 61.5% said that occasionally they are under stress and they don't always have as much as energy as they did, but they don't feel burned out. Stage 1 is completed and PDI is still in progress. Post-survey will be run in February and to observe how the measures in the current study change and whether these changes are more evident in 6 participating area mental health services which were participating in the PDI. This would suggest that the PDI may be positively changing the mental health workforce's ability to support and treat people experiencing difficulties related to personality disorder.
Thank you very much, Parry, for that marvellous insight into Victoria's public mental health workforce. We can see that there's quite a lot of need in terms of experience and mentoring and training for helping people with personality disorder. What we didn't present today is that there was a lot of just free comment feedback on that survey as well, thanking us for running the survey and saying that they were really keen to learn. They just were waiting for opportunities to do so. So it's a very encouraging piece of work. So our final rapid fire presenter for this session is a long-time colleague and friend, Ms. Rita Brown. Rita is Spectrum's carer consultant who draws on her lived experience as a family member of someone with BPD to advocate for the needs of families and friends. Rita is also president of the Australian BPD Foundation and board member of the Australasian chapter of the International Society for the Study of Personality Disorders. Rita will present a soon-to-be published evaluation of carer-designed and led workshops for families.
Hello, my name is Rita Brown, and today I will be presenting on the results of single-session interventions for carers supporting someone living with BPD that we researched here at Spectrum in 2018-19. The interventions were titled Learning More About Borderline Personality Disorder. I am the mother, carer of a daughter diagnosed with BPD. Like most people who see someone they love in distress, I feel that I share part of her struggles. I don't feel that anyone can really understand that often seemingly bottomless pit of despair, self-hatred, worthlessness and emptiness she tried to describe to me, and which I saw her struggle with. Out of love and empathy, I rushed in and tried to protect her from herself. Tried to fix her things. If only she would listen and do what I suggested and bend over backwards to try and keep her happy and safe. Out of desperation and anxiety, I can now acknowledge that I behaved in ways that were not true to my values and which alienated her, exhausted and frustrated me, and left us isolated from one another. It took me a long time to realize that I couldn't love her back to wellness, and this is at first really hard to accept. I felt like I had to deny all my mothering instincts. However, with appropriate support and education, it became liberating to focus on what I could do, which was provide a loving and supportive environment leading to better outcomes for all. The National Health and Medical Research Council clinical guidelines for BPD recommend that healthcare professionals support families, partners and carers of those with BPD by providing clear and reliable information. When I started working for Spectrum in 2016, I was tasked with conceptualizing, writing and facilitating these single session interventions informed by my own lived experience as a carer, with an experienced mental health nurse taking a secondary supportive role. The power of a shared lived experience is powerful and unique. My experience is that a message given by a peer often resonates more than if exactly the same message is given by a mental health clinician. Due to limited healthcare resources, it was envisaged that single session programs would provide a more practical approach to offer support to more carers. The term carer in this study refers to people who support someone with BPD in a voluntary capacity. It's inclusive of biological family, parents, grandparents and children over 18, and non-biological family of choice, such as mob, partners and friends. It's important to note that many carers do not identify as a carer and see themselves doing what a caring person does when they're supporting someone in distress. The distress of carers who come to the sessions is often profound. A range of feelings and experiences expressed include blame, guilt, anger, resentment, anxiety, grief, loss, hopelessness, and powerlessness. Families also often experience stigma and discrimination and social isolation. In addition, many also find themselves with financial and/or housing strain and poor physical health. Vicarious trauma is common. 2 single session interventions were developed. The focus on the shorter 2.5-hour information session was on providing information about BPD to support the carers to develop an understanding of the disorder and how best to support the person in a sustainable way. The 7-hour workshop builds on this and introduces educational and practical approaches to learning new skills such as acceptance, listening, validation, and establishing compassionate boundaries or limits. Both interventions promoted the importance of self-care and provided guidance for further sources of information and resources for both carers and for the person with BPD. The 7-hour workshop allowed a much greater opportunity for sharing, networking and discussion. To my knowledge, this is the first study investigating single session interventions for carers that are conceptualized, developed and led by a carer peer and not based on a specialist therapeutic model. The majority of participants self-referred, with a small number being told about the intervention by a mental health worker. Interventions were each attended by 11 to 24 carers and for the workshops held during 2018-2019. Participation in the study was anonymous and voluntary. Participants registered via an online booking portal and were individually emailed a week before the sessions with information about the study and requested to complete 3 baseline questionnaires to explore their self-reported understanding of BPD. Just going to share my screen. And the impact of supporting a person. At the conclusion of the session, participants completed the scale assessing knowledge of BPD again and a customised satisfaction questionnaire. The other 2 questionnaires were emailed to participants 1 month after the intervention. In total, 369 people self-identifying as carers of a person with a diagnosis or a possible diagnosis of BPD participated. 261 carers attended the 7-hour workshop and 108 attended the 2.5-hour information session. So who attended? Participants were predominantly parents of people with BPD, with the majority aged between 41 and 75 years. The average distance travelled to attend was 77 kilometres, with 3 participants travelling from interstate. Occupations and educational levels were diverse, from stay-at-home mums, tradies, those retired, to mental health professionals and professors. We highlighted the need for an inclusive, safe, non-judgmental space, respecting that everyone is doing the best they can, often under extremely challenging circumstances. We spoke about the power of language to hurt, and manipulation is a big one here. We acknowledged how difficult it may be for them attending, and for many it was the first time they've been able to speak openly and feel heard. Regular breaks were offered, and these were considered to be an important aspect of the day. The break shared over food encouraged participants to relax, to network, or to speak one-on-one with the facilitators. The opportunity to meet other carers and realise they're not alone, and the value of the lived experience of the peer facilitator featured highly in the qualitative feedback. Most participants rated all aspects of the intervention being relevant to them. It was interesting to note that the relevance of some aspects of the program depended on the relationship of the person to the person with BPD. For instance, pathways to the development of BPD was not considered relevant by children with a parent with BPD. Likewise, self-harm and risk was not considered relevant for participants where their person did not engage in self-harm. Both single session intervention formats resulted in meaningful improvements in participants' knowledge about and attitudes towards BPD. The carer participants' burden assessment score and ECALM scores improved following interventions, although the improvement in BAS score was only statistically significant for the 7-hour workshop. There were small but significant reductions in K10 scores for both intervention. The full-day workshop also reduced the perceived burden associated with caregiving, highlighting the community need for longer-term support. Thank you very much for listening.
And thank you, Rita, for all the marvellous work you do, both at Spectrum and nationally. This concludes our rapid fire session. I'm sure you join me in thanking all of our rapid fire presenters for providing such concise and informative insights into a range of topics.